So today we're going to discuss double inlet ventricle. And you can have either double inlet left or right, although left is by far more common. And what do we mean by double inlet ventricle? Well, it means that both atrioventricular valves enter the same ventricular chamber. Here you can see an example of that. Here's the right atrioventricular valve up here at the top, the left down here toward the bottom. This is a left ventricle. You can see the smooth septal basal surface over here, the fine trabeculations, free wall papillary muscles. So this is a double inlet left ventricle. And you can see if we put our palm against the septum here, thumb into one of the AB valves and fingers out the outflow, this is the pulmonary valve right here. This is the outflow foramen or bulboventricular foramen or VSD or whatever name you hear for this. And so that takes a right hand to be able to do that. So this is an inverted or L-looped left ventricle, and we'll see that's by far the most common arrangement that we see in double inlet left ventricle. Now, there is the main chamber which receives the two atrioventricular valves, but if you go through the outflow foramen here, we usually end up in a small outlet chamber, at least with double inlet left ventricle. We'll see that's not the case with double inlet right. But usually with double inlet left, then we end up in a small outlet chamber. Here the probe has come through, it's gone through this little opening right here into this small endocardially lined chamber which supports the other semilunar valve, usually the aortic valve, and that's the case here. And you can see there's really very little to this chamber. It's mostly just the old outflow of the heart. Some people consider this a hypoplastic ventricle. It's okay if that's what you want. We don't really know whether there's right ventricular myocardium here or not. There may be, particularly when the outlet chamber is a little bit bigger, as we'll see. Now, there are a number of types of double inlet left ventricle, which we said is by far the most common type. It's orders of magnitude more common than double inlet right ventricle, which is pretty rare. As I said, most commonly we have L-looped ventricles and L-transposed aorta. That makes 60 or so % of double inlet left ventricle. So it's double inlet left ventricle with transposition, soletus atria, L-looped ventricles, and L-transposed great arteries. A bit less common, 20, maybe 30% of these, something in that range. These are approximate numbers, of course, and depends on what study you read, what compilation of defects. But certainly a fairly distant second type of double inlet left ventricle, is with D-looped ventricles and a rightward aorta, D-transposed aorta, so double inlet left ventricle with transposition SDD. And then a relatively rare type carries the moniker Holmes heart, because Dr. Holmes described this, but it's a double inlet left ventricle with normally related great arteries, not transposition, but normally related great arteries. So soletus atria, in this case, these are D-loops, and soletus normally related great arteries, aorta from the double inlet left ventricle, and the pulmonary artery from the outflow chamber. And this makes somewhere around 10–12% of double inlet left ventricles. And then double inlet right, as I say, is quite uncommon. Well less than 1% of autopsies here, and that certainly is only a small part of the population with congenital heart disease. And of these, they're all double outlets. Obviously, there's no other ventricle really there for a great artery to come from, so they're double inlets and double outlets. Often we can't tell the ventricular loop because we can't find a left ventricle. Often it's either invisible, so small, or absent. We don't really know for sure. And that's true in the majority of cases, about 70 or 80% of cases, and only in a minority can we find a left ventricle, in which case you can tell what the ventricular loop is. If there's only a right ventricle and you don't know where the septum is, it's hard to assign a loop You can't really use the hand rule. So very often these are X loops. Remember when we discussed segmental diagnosis before, we said that this was the time, about the only time, when we couldn't tell what the ventricular loop was. So what happens? What's the development of double inlet left ventricle? Well, of course, we don't really know. Nobody's ever seen one of these hearts develop, certainly in humans, and we don't have good um, animal models for this. But based on what we know about cardiac development and what this ends up looking like, we can at least speculate. And we know that early on, Carnegie stage, say 13 or so, whoever just joined, mute yourself, please. Please, whoever just joined, mute yourself. You're making a lot of noise. Ooh. Please, when you join, it's fine to come in late, but please remember to mute yourself. Anyway, so at this stage, we have the complete AV canal between the developing left atrium and left ventricle. And we know that a couple of Carnegie stages later, by around 15 or so, the AV canal begins to expand to the right. And it does so first under the atria without expanding across the interventricular foramen into the right ventricle. So now the AV canal drains both atria, but only to the left ventricle. And we think that what happens is that things get hung up at this stage. This is a 17, just before we start to see the AV canal move across into the right ventricle. We think that things sort of get hung up here. The atrial septation complex continues to grow in, closes the primary interatrial foramen. The AV cushions fuse to form two atrioventricular valves, but both of those valves are aligned with the left ventricle, neither with the right ventricle. Occasionally, we see a little bit of straddling of the AV valve closest to the right ventricle, whichever side it's on, or the outflow chamber. And you may see a little cord going into there, and probably the arrest was a little bit later, and the canal started to go over to the right ventricle, but really didn't complete it. So that's what we think causes double inlet left ventricle. And as I say, the most common type is with L-looped ventricles, and we already looked at this heart. You can see here's one AV valve up here, here's the other AV valve down here. They're both coming into this left ventricle. Here's the pulmonary valve right here. There's a little ridge under the pulmonary valve. We often see complex pulmonary stenosis in these patients. Sometimes the infundibular septum can cause pulmonary stenosis, sometimes fibromuscular ridge like this, sometimes accessory AV valve tissue like this. You can see this is part of this right-sided AV valve. Has some accessory tissue here and an attachment over toward the septum, and that can sometimes cause subpulmonary obstruction. If the outflow foramen is small, then that causes usually subaortic obstruction in this. And here you can see, again, the outlet chamber on the other side with the aorta sitting up here above it. This is all conal muscle or outflow muscle here under the aortic valve, supporting the aortic valve. Now, in contrast to that, remember here, in this one, we're looking at it, the septal surface is over here toward the left of the patient, whereas in this heart, this is another double inlet. You can see here's one AV valve, here's the other AV valve coming into this ventricle. Oh, another thing to point out is the pulmonary valve, or the valve that comes from the main chamber here, sits between the two atrioventricular valves. And that's typical. It's often in fibrous continuity with both of them. So here again in this ventricle, you can see here's one AV valve here. Here's the other AV valve up here with papillary muscles. And here is the pulmonary valve sitting again in between the two atrioventricular valves. Now notice in this heart, the septal surface is over here toward the right. This is the smooth septum, apical, fine trabeculations, free wall papillary muscles over here on the free wall. And this has another feature that we see both in double inlet lefts and sometimes in double inlet, or actually even more often in double inlet rights, is this muscle bar on the posterior-inferior wall, here on the free wall between the two atrioventricular valves. This has been called a posteromedian muscle ridge or posteromedian ridge, and it's a feature that we not infrequently see in these kinds of hearts. In this case now, the outflow is over here on this side, and this right AV valve is close to the outflow in this case. Now, in this one, if we put a thumb into the AV valves, our palm against the septum and fingers out the outflow here, you see this is a left-handed left ventricle. So this is what we would expect from a left ventricle. This is a D-loop left ventricle. And if we go through here again, just like in the other heart, but now going to the right side instead of to the left side, we find an outlet chamber that again supports the aortic valve on the other side. It's a little bit bigger in this case, and has, as you can see here, this little attachment of the right AV valve coming into here. So there's minimal straddling of this right AV valve into the outlet chamber. And this is not an uncommon finding in double inlet left ventricle. And it's probably one of these little attachments right there that you see from this side that we can also see from the outflow chamber side. And here the aorta is to the right. This is a D-looped and D positioned aorta, D-transposed aorta. And just to contrast these, you can see we put them together here. Here's the septal surface of this one. Here's the septal surface of this one. So you can see they're more or less mirror images of each other. The free wall papillary muscles are over here. In this heart, the free wall papillary muscles are over here. So again, more or less mirror images of each other. L-looped on this side, D-looped on this side. And what this looks like by imaging, here you can see both of these atrioventricular valves are entering this ventricular chamber. And here we see in a subxiphoid view, you can see this is a big left ventricle. Here's smooth septal surface right there. Here's one AV valve, the left AV valve coming into this ventricle from the left atrium. Here's the right AV valve coming into this ventricle from the right atrium. And so here we have our big left ventricle, again, smooth septal surface. And here's the pulmonary artery. You can see it bifurcating up here, coming out of this left ventricle. There's the right pulmonary artery coming out. There's the left over there. So again, here they're coming together to form the pulmonary trunk, and that comes out here. Here's infundibular septum. It's the little muscle bundle right there next to the pulmonary valve there. And then here's the aortic valve coming out of this little outlet chamber up here. Here you can see this left-sided outlet chamber leading to a left-sided aorta. So this is transposition SLL. And here the outflow foramen is pretty good size. The infundibular septum is not really in line with the rest of the septum. It's pointed down here. And so that leaves a pretty good opening here for aortic outflow. And if we look at this in a parasternal short axis view, here's our left ventricle over here, just opposite. Usually we would expect the septal surface to be on this side, but in this heart, it's over here to the left. So this is a D-loop. This is a mirror image of what you would expect to see. Two AV valves coming in here, seen in cross-section. Here's the outflow foramen right there. Pulmonary valve is going to come out of here, and aortic valve out of this little outlet chamber. And there's a coronary coming from the aorta. So again, you can see this in a parasternal short axis view. Now here's one that's in dextrocardia. Abnormal heart position is not so infrequent in this. So here's right atrium left. Here's our left ventricle. Here's the aorta. Here's the pulmonary artery. You can see both AV valves are coming into this ventricle with the apex over here pointed to the right. Here's the PA coming out of the main chamber. Here's the aorta coming out of this little outlet chamber up here anterior and to the left. And so again, this is soleus atria, right atrium here, IVC coming up into it, pulmonary veins into this atrium, L-loop ventricles because the septal surface is over here toward the left instead of over here toward the right, and the aorta is here anterior and to the left. Now here in contrast is a D-loop one. So here's our PA, posterior and to the left, and here's the aorta, anterior and to the right. More or less anterior in this case. Both AV valves again entering this left ventricular chamber here. And here's the septal surface up here. Here's the outflow chamber up in the front. Whoops. And if we look at this in a short axis, here you can see the big PA in the back, the aorta in the front coming from this little outlet chamber, which is anterior and rightward. Here you can see again one AV valve, the other AV valve, both coming into the left ventricle with the outlet chamber up here giving rise to the aorta, the PA, the big PA here coming out of the main chamber. So patients like this are ones who sometimes have outflow obstruction. So these with transposition, double inlet with transposition, depending on the size of the outflow chamber, if it's and the outflow foramen, if they're small and obstructive, we can see circulatory collapse when the ductus begins to close, or these patients may have relatively unobstructed pulmonary blood flow and be in heart failure from excessive pulmonary blood flow, or they may have quite a bit of pulmonary stenosis and present more with cyanosis. Whether there's a murmur or not depends on mostly on whether there's outflow tract obstruction, because we don't see all that much AV valve regurgitation in patients like this, at least early on. Pulses are variable, may be down if there's outflow tract obstruction to the systemic outflow to the aorta. We may see a big liver if there's heart failure, and of course cyanosis. The EKG can be relatively non-specific, and this may not be very helpful. Chest X-ray often shows a big heart, increased flow, or it may show normal heart size and decreased flow if there's a lot of pulmonary stenosis. Now, one of the things that has to be examined and we have to try to determine relatively early on is whether there is systemic outflow tract obstruction. And you can see a lot of different looks to the outflow. Here's one where the infundibular septum is more or less in line with the septum, and this often results in a small outflow foramen or a VSD with a little outlet chamber up here with the aorta coming from it, with a big pulmonary artery, a lot of pulmonary flow, but restricted systemic flow. Or we may have something like this, where the infundibular septum curls back under the pulmonary artery, and you have pulmonary stenosis and relatively unobstructed aortic outflow. Or you can have basically no infundibular septum. Or this is a D-loop. This is a SDD with the aorta to the right, PA to the left, and the outflow chamber here to the right. And this is a pretty good size outflow chamber. You could certainly make an argument for being some right ventricular myocardium here. But this one has a couple of communications. The usual one here between infundibular septum and the rest of the septum, the outflow foramen or bulboventricular foramen. But it also has a muscular defect down here closer to the apex of this little ventricle. So these are almost always obstructed. When the infundibular septum's in line with the rest of the septum, or if you have these little muscular defects like this, they're almost always obstructed. One way that we have found, this was a study that Abraham Matityaw did many years ago when he was a fellow with us. We measured the bulboventricular foramen or outlet foramen in patients like this, and we measured it in 2 dimensions and used the formula for an ellipse to calculate the cross-sectional area, because the single dimensions of this really weren't very helpful. The only thing that really correlated with anything was the cross-sectional area calculated in this way. And what we found was that basically, and these were all done in the first month of life, any baby in the first month of life who had an outflow foramen area adjusted for body size that was less than 2 square centimeters per meter squared became obstructed. All of them did. Whereas anybody above 3, none of them, at least for several years, became obstructed. And then there was a little group in between where it was sort of hard to tell, somewhere between 2 and 3. And what happens is that the outflow foramen doesn't grow. It stays about the same size, and this is body growth up here. So despite body growth, this stays the same size, so it becomes relatively smaller compared to the patient's cardiac output, and that's why these things tend to become obstructed over time. If you adjust it for body surface area, it gets smaller, actually, once you adjust it for body surface area. And then the last type is a double inlet left ventricle with normally related great arteries. And here you can see still frames of this. Here's the left ventricle, mitral valve, aortic valve. Looks like a usual peristernal long axis view. Here's the infundibular septum, and the pulmonary artery is sitting here above the outlet chamber. You can see both of the AV valves come into this single left ventricular chamber. If we look at this in what looks like a peristernal long axis view, you can see there's essentially aortic to mitral fibrous continuity here, and the pulmonary artery arises up here from the outlet chamber with a big outflow foramen here. And here in short axis view, you see the aorta posterior and to the right, PA anterior and to the left, like normally related great arteries. And the PA is aligned with the outlet chamber. The aorta is aligned with the main left ventricular chamber, and both AV valves coming into this ventricular chamber. So this is a Holmes heart, or double inlet left ventricle with normally related great arteries. Now, sometimes we see inflow obstruction as well. One of the AV valves can be quite small. Here you see in this heart, this right AV valve is quite small. The left AV valve is good size. And here you can see with color flow, you see this right AV valve is quite small, can be either one. And here you see there's an aneurysm of the atrial septum, and this can be a real clue that one of the AV valves is quite functionally small when you see this big aneurysm of the atrial septum. And of course, coarctation occurs in these patients with, particularly with outflow obstruction to the aorta. Most commonly, of course, in those with transposed great arteries, which is the majority. But here you can see here's a big ductus, and there's a very narrow distal aorta isthmus and the coarctation, the discrete coarctation there. And you can see with color flow, a continuous flow coming across this area with narrowing here as you join the ductus arteriosus. So that's double inlet left. Let's look at a couple of double inlet rights. Here's one. And look at this ventricular chamber. We've opened it widely down here. Here's one AV valve, the right AV valve. Here's the left. And you can see this is a very heavily trabeculated chamber. And we don't see anything that looks like the smooth septal surface that we saw in the double inlet left ventricles. And not only that, we don't see the clear demarcation between the pumping chamber, the ventricular chamber, and the outflow. Here, there's just a direct continuity between the inflow part of this ventricle and the outflow. Here's a pulmonary valve, here's an aortic valve up here, here's infundibular septum here in the middle. And you can see that you could just go directly from the inflow part right to the outflow part without there being any kind of outflow foramen or constriction or anything like that between the two. And we think that's because the right ventricle develops from balloons out from under the old outflow, which is where the aorta and pulmonary artery are up here. We don't really understand the origin, the embryonic origin of double inlet right ventricle, particularly because there's never a time during normal embryogenesis when both AV valves are aligned with the right ventricle. So we don't really understand how this happens or what happens to the left ventricle in hearts like this. It's possible that the left ventricle just develops but then involutes. It's possible that it really never forms, particularly in somehow the AV canal gets aligned with the right ventricle, but this is really poorly understood. This is another example. Here you can see the right AV valve over here, a smaller left AV valve on this side, and behind there you see an opening. And on the other side of that opening is this little left ventricle. So here's the smooth septum here, and it's just a very small chamber. That's really all there is to it right here, this little endocardially lined chamber right here. And you can see here's the left AV valve. It's just on the other side of this view here. But the left AV valve attaches over here into the right side, and nothing comes into this left ventricle. There is a ventricular septal defect. And again, you see the outflows up here, aorta, pulmonary artery, infundibular septum here in between, and you see how this inflow part of the right ventricle here just continues directly into the outflow part. Here's an example by echo, right atrium, left atrium, two AV valves coming into this big trabeculated ventricular chamber here. You can see there are trabeculae all around, no smooth septal surface anywhere. And here's the outflow coming directly out of this big ventricular chamber. Aorta here, PA here, and you could see the infundibular septum was in fact curled under the pulmonary artery and causing some subpulmonary obstruction in this case. Here's infundibular septum right there. You see how it obstructs the subpulmonary area here. But again, this big heavily trabeculated ventricle with no evidence of a septal surface. Here's another one. It's a bicable view, left atrium, right atrium, 2 AV valves coming into this big chamber. And, and this one had pulmonary atresia, so there's just an aorta coming out of here. And you can again see this big heavily trabeculated chamber down here with all these muscle bundles and no evidence of anything like a smooth septal surface. So that's basically what these look like. The treatment for this, many of these patients, maybe most, need some kind of early palliation, sometimes an atrial septectomy to improve mixing, or if one of the AV valves is small, to relieve venous obstruction. And then we often have to address systemic outflow tract obstruction with an aortopulmonary amalgamation early on sometimes. And then, of course, you have to provide a source of pulmonary blood flow. In older patients, VSD enlargement has been performed. This has been pretty tricky in small babies because of the difficulty of trying to enlarge this in a very small heart. And then if there's significant pulmonary obstruction, some of these patients need a shunt before going on down the pathway being staged toward a Fontan operation. So initial palliation, then Glenn, and then Fontan. And many of these patients end up, particularly double inlet rights, end up with a heart transplant or some kind of mechanical support, ventricular support later on. Outcomes for Fontan, we know, are not great. These are data from the Mayo Clinic published about 4 or 5 years ago. And you can see that this is some of the longest term data available. You can see that at 20 years, in their experience, only about 65 or 70% of patients are still alive. And at 30 years, it's only maybe 45 or so % alive. And by type of Fontan, you can see here extracardiac conduit in their experience did a little better. All the other ones did similar. That's not been our experience. The lateral tunnel would be up here with extracardiac conduit or very close to it, and AP, aortopulmonary connection, is certainly substantially worse. Now, if you look at it by disease, here's double inlet left ventricle. What we're talking about today is the red dashed line here. You can see it's sort of in the middle. Heterotaxis clearly do worse. Hypoplasts in their experience did better, at least early on. This is only 5 to 10 years out here, but you can see double inlets sort of here in the middle. And in Australia, New Zealand, they have a large registry for Fontans there. And you can see that the data are similar. 20 years, it's about 75% survival, similar to what the Mayo Clinic found. And they found that extracardiac and lateral tunnel were about the same, with aortopulmonary obstruction being worse. And this is just freedom from adverse events. You can see at 20 years, it's only about 30–40% of patients free from adverse events. So we know all of this. Double inlet lefts do better than tricuspid atresia with transposition because these often have outflow tract obstruction. And double inlet ventricles do better than common inlet. We do occasionally see patients with a common inlet ventricle where there's a common AV valve. So now we want to look at some specimens of double inlet ventricles. And we'll start with double inlet left ventricle. This is the most common type, as we said, is where there is an L-looped ventricle and left-sided aorta, double inlet LVSLL. So this is an example of that. Here we're looking at the heart from the front. Here's our right atrium. You see the fossa there. And if we go through the right AV valve, you can see we end up in this big ventricle. Has a smooth septum over here, free wall papillary muscles on the other side. And if we look from the other atrium here in the back, you can see a typical left atrial appendage here. And you see the primary atrial septum here on the septal surface. Here's the septum primum right there. So this is our left atrium. And it goes through the left-sided AV valve here into the same chamber as the other AV valve. And this is clearly a left ventricular morphology. You can see the smooth septum here, again, the free wall papillary muscles out here with both atrioventricular valves entering it. Now, this is an L-looped ventricle. We can apply the hand rule to this. And so an inverted or L-looped left ventricle would be right-handed. It's the opposite of a normal left ventricle. So if we put a thumb into the AV valve, fingers out the outflow, here's the pulmonary outflow from this ventricle, and our palm against the septal surface, this is a right-handed left ventricle. I can't do that with my left hand. So this is an inverted or L-looped left ventricle. And you can see both of the AV valves enter here. And typically there is fibrous continuity between the pulmonary valve and the two atrioventricular valves. And the pulmonary valve, which is usually the outflow in SLL transposition, it's the outflow from the left ventricle, sits above the two atrioventricular valves here, just as we see here. And here you can see this is the pulmonary trunk. Now, if we look at the interventricular septum, you see there's an opening here that takes us into this left-sided outlet chamber on the other side. And you can see there's really not much to this chamber, a very small little trabecular area here. Mostly this is just an outflow. This doesn't extend far down to the diaphragmatic surface of the heart. And here the semilunar valve supported by this little outlet chamber is the aortic valve. Here you can see a coronary ostium, and you can see brachiocephalix in the arch coming from it. So this is the aorta, and the aorta is to the left and anterior to the pulmonary artery. Here, if we put this back together, this is levocardia. So here's the pulmonary trunk posterior and to the right, and the aorta here anterior and to the left. So this is the soletus atria that we saw, and L-looped ventricles, and an L-transposed aorta. This is double inlet left ventricle with transposition SLL. And as I said, this is the most common arrangement that we see in double inlet left ventricle. Now, there are some variations on this. That one had a large outlet foramen to the aorta. Here's another double inlet. You can see here's one AV valve, here's the other. And this is the pulmonary outflow in this case. You can see, again, it's sitting between the two atrioventricular valves, but it's quite obstructed. There's a lot of fibrous tissue here. The pulmonary valve is very abnormal. So there is outflow tract obstruction here. And here's the outflow foramen here to the other outlet chamber, and you can see it's quite small, quite obstructed. Here's the outlet chamber on the other side, again supporting the aorta. There's the aortic valve up there. So this is a heart with bi-outflow tract obstruction, and you can see how massively hypertrophied this is. This is one of the complications that can occur with double inlet left ventricle is outflow obstruction of one or the other, or rarely, as in this case, both. And so this patient died from complications of that. And we can see abnormally formed atrioventricular valves as well. Here's an example. This is the other type, but I'll just show you. If we look at, this is an explanted heart. If we look from above here, you can see one atrium. Here's the other atrium over here. There's one AV valve. There's the other AV valve. So two AV valves. Here are the great arteries up here. So this is the pulmonary trunk here. Here's the aorta up here. There's the little outlet chamber here. And the main ventricular chamber is here. And so you see the two atrioventricular valves coming into this. And in this case, one of these, the left AV valve here, has a big cleft in the anterior leaflet here. So that's what I really wanted to show you with this, is that you can have abnormalities of the atrioventricular valves, such as a cleft in the anterior leaflet of one of the valves. The other valve is this one back here in the back. And so this is one of the abnormalities that you can see. We'll see others in other examples, but this is a cleft valve. Now, the second most common arrangement that we see in patients with double inlet left ventricle is where there is a D-loop, usual arrangement of the ventricles, and D position of the aorta. And that's what we see in this heart. So if we look here from the front, we're looking at the front of the heart here. This is the aorta here. There you can see a coronary. And the pulmonary trunk is over here to the left of it. There has been an aortopulmonary anastomosis created here. This is pulmonary artery. This is aorta. And you can see the aortopulmonary anastomosis here that's been created because of the severe outflow tract obstruction to the aorta. There's solipus atria. Here's our right atrium, which is right-sided in this case. And there's the interatrial communication. You can see there's a secundum atrial septal defect. This is the right atrium into this right atrioventricular valve right there, that one, into this left ventricle. And then if we look at the atrium on the other side, here's our left-sided atrium. There's the atrial communication again right there, and it goes through this left-sided atrioventricular valve right here into the left ventricle as well. So both of these atrioventricular valves, the right and the left, come into the left ventricle. Here's our smooth left ventricular septal surface here. And this is the outflow from this ventricle to the pulmonary artery, which is right there. And if we go up, you can see we're in the pulmonary artery on this side. That's the one side of the aortopulmonary anastomosis. You can see the sutures in it there. So this is the pulmonary artery. And then the communication with the aorta is right there. That's to the subaortic little chamber here. And now this chamber is right-sided. Before, remember, we saw the chamber on the left side. Here, this little chamber, this smooth wall chamber here, is right-sided, and it supports a right-sided aorta. Here's the aortic valve. We already saw the aorta here. There's the coronary, and its connection to the created connection to the pulmonary artery there, an aortopulmonary anastomosis. So the aorta here is to the right. And if we look at this left ventricle, here's our septal surface, there's the outflow, here's the inflow. This is a left-handed left ventricle. I can't do that with my right hand. This is thumb in the AV valve, finger out the outflow there, and palm against the septum. This is a left-handed left ventricle. So this is a D-loop, or a usual kind of left ventricle. And going along with that, the outflow chamber is here right-sided, and the aortic valve is also right-sided. So this is SDD type of double inlet left ventricle. So as I say, this is the second most common type of double inlet. And then the least common type is this one. And this has an acronym associated with it. A Holmes heart. Dr. Holmes described this kind of heart. And here we see the aorta. Over here, posterior and to the right, this was the pulmonary valve, which is anterior and to the left. So these are like normally related great arteries. So if we look back here, this patient has had a type of Fontan operation, so we see a big patch here within the atrium. And that's the connection to the pulmonary artery. The superior vena cava comes in here, inferior vena cava comes in here. This was a patch placed to segregate the systemic venous return from the two atrioventricular valves. So we can't see either AV valve from here. It's somewhat like a lateral tunnel, but not exactly, because the pulmonary trunk was connected directly to the atrium. But in any case, if we open this ventricle and look in, you can see here's this big right atrioventricular valve and a smaller left atrioventricular valve here. So you can see some disparity in the sizes of the two atrioventricular valves. Here's our smooth septal surface over here, free wall papillary muscles. Again, this is a left-handed or D-looped left ventricle. And here's the aortic outflow. We come through here, we end up in the aorta. So the aorta is aligned now with the left ventricle, so normal alignment. The pulmonary trunk was aligned with the outlet chamber, which is here. There you can see a big communication back with the left ventricle here. And so this is a right-sided outlet chamber that went up to this pulmonary valve. It's all been obstructed now because of the Fontan. You can see sutures up here where the pulmonary outflow was obstructed. But this was the right-sided pulmonary outflow, and then the infundibulum under the left-sided pulmonary artery. So these were normally related great arteries, normally connected, with the aortic valve sitting here between the two atrioventricular valves and in continuity with them, and the pulmonary trunk coming from here. And this patient also has an additional communication here between the left ventricle and the outlet chamber here. It's a little more apical and more like a muscular defect as opposed to the usual outlet foramen that we see up here. So you can have multiple communications between the left ventricle and the outlet chamber in any of the types. This one just happens to be in a Holmes heart. And you can see also that this left AV valve is quite a bit smaller than the right. And if we look at it from the left atrium, you can see that it has a supravalvar stenosing ring as well. You see there's a little ring of tissue here around this orifice of the valve, around the annulus of the valve, causing some obstruction and associated with the small valve that we saw in this patient. So you can see a little stenosing ring, and there's a big interatrial communication created here so that drainage from the pulmonary veins can also go through this big right-sided atrioventricular valve. This was around the time of the Fontan operation when that was all done. So this is a Holmes heart, or double inlet left ventricle with normally related great arteries, S, soletus atria, D-looped ventricles. We saw it was the left-handed left ventricle, and soletus, S, normally related great arteries. Aorta posterior and to the right, PA anterior and to the left. Aorta aligned with the left ventricle and normally connected with aorta to AV valve fibrous continuity, and the pulmonary artery aligned with the outlet chamber here and normally connected to it with a complete subpulmonary infundibulum. So this is a Holmes heart, or double inlet left ventricle with normally related great arteries. So those are the types of double inlet left ventricles that we see. It's also possible to see a double inlet right ventricle. They're quite a bit more rare, but they do occur. This is an explanted heart from a patient with double inlet right ventricle. And if we look from up here, you can see there's one atrium. Here's the remnant of atrial septum. Here's the other atrium and two separate atrioventricular valves that we see. Here's one appendage, the other appendage over here around the vascular pedicle. And in this vascular pedicle, we really only see this one semilunar root, which is the aorta, because this patient had pulmonary atresia. And if we look inside, now we see a very heavily trabeculated ventricle. This one's quite hypertrophied as well. But we don't see any wall anywhere that looks like the smooth septal surface that we saw in the left ventricles. For example, if we compare this with this double inlet left, you can see there's a clear septal surface over here, smooth septum, and there's an outlet foramen that leads to the outlet chamber on the other side. So those are two characteristics of double inlet left. But if we look at this double inlet right, we don't see anything like that. There's no smooth wall here. It's all just heavily trabeculated. We can see the two AV valves. Here's the right, here's the left as they're coming into this chamber. And one of the features we often see in these is a posterior median muscle bar like this posterior ridge, posterior inferior, between the two atrioventricular valves, often with attachments of the valves to it. And then above the trabeculated chamber here, it just goes directly into an outflow. The aortic outflow is there. There's aortic valve right there. And this was the pulmonary valve. It was either oversewn or was atretic. And this is infundibular septum, but you can see there was substantial pulmonary outflow tract obstruction in this patient. But notice how the outlet just continues directly from the ventricle. There's no real separation between the two. And that's because embryologically, you know, the right ventricular sinus just develops from the base of the outflow. It just balloons out from it. And so that's why there's no constriction here, no septum, no smooth septal surface, nothing like that, just a direct continuation from the sinus of the right ventricle into the outflow. So this is a double inlet right. And this patient really had no demonstrable left ventricle. So we don't know where the septum is in that heart. Now, if we look at this one, this is a little heart. So we'll zoom in a little bit on this. And this is not an explant, so we have the whole thing here. So again, you can see that there are two AV valves here, a bigger right, a smaller left, which we can see a difference in the size of the AV valves in some patients with this. Here's our atrium back here. This is the right atrium over there. There's a big created communication atrial septal defect there. And the left atrium is over here on this side with pulmonary veins coming back into it. Superior vena cava coming into this one, right atrial appendage. You can see this patient has had surgery. There's a atriotomy that's been closed here. There's the plane of the septum and the two atrioventricular valves on either side. So here's right, here's left, both again coming into this very heavily trabeculated chamber. We don't see anything that looks like a smooth septal surface. And here's the outflow, again coming directly from the chamber right into the outflow. Here's aorta, pulmonary artery, and here's the infundibular septum, or outlet septum. And so you have the two outlets just coming directly above this heavily trabeculated ventricle. So this is a typical pattern that we see in double inlet right, where there's not a clear separation, in fact, just a continuation from the trabecular chamber below to the outflow and to the two semilunar roots. I'll show you one other one here, because this one has a couple of features. One, here's our ventricle, which again you can see is heavily trabeculated. But here you can see one of these AV valves is quite small. This right AV valve is really quite small. So this could, if there was no atrial septal defect, this could produce systemic venous obstruction. The left AV valve on the other side is quite large and drained the left atrium on this side. But there was a big interatrial communication, or at least one created in this patient, so that there was no systemic venous outflow obstruction. And here, again, you can see the outlet up here. Here's the aortic valve on this side. This is infundibular septum. Pulmonary is over here, it's quite obstructed. Severe pulmonary stenosis in this case, which is not uncommon. So that's, again, the outlet coming directly above this trabeculated chamber down here with both inlets. And here's this posterior median ridge, again, that we sometimes see in the inferior aspect of these ventricles. And in this case, however, there is a little other ventricular chamber here. There's a little smooth septum right there, ventricular septal defect. So this is a little left ventricle in this patient. So some of these patients have a demonstrable left ventricle. There's no AV valve coming into it. You can see part of the small right-sided AV valve there associated with it. This little left ventricle was right-sided in this case. And so this is a patient with a very small right AV valve, a tiny right-sided left ventricle, and just this big double inlet right ventricle. And in this case, there was dextrocardia.